Well, I'm going to talk about heart rate variability. Dr. Mulier has honored me in a way that he has set up very clearly the importance of the inflammation of the autonomic nervous system stress and the possibility to control it. And you can only control what you measure. And heart rate variability, it seems to be a good way to measure the autonomic nervous system response to a stress. So it might be a good tool in order to help clinicians to control that surgical stress. And I like very much to talk about heart rate variability as the fifth vital sign. That's why I took this image from Costa Rica, which his theme is Pura Vida, which means pure life. You can see the water, the life of the plants, the fishes, everything. And I like to talk about heart rate variability, the fifth vital sign, because heart rate variability is the sign that we get from the autonomic nervous system, and this system is the one that is managing the energy that is needed in order to be alive. Life is always about energy and how we manage it, and the system that is managing this life is obviously the autonomic nervous system. We are going to use this energy in order to fight or flight in case of the sympathetic activation, in case that we have an acute threat that we have to respond to. It could be an internal threat or an external threat, like a lion, for instance, or a bacteria inside our body that needs to activate the immunitary system, and that will be, as Dr. Mulier has done, thanks to the sympathetic activation. Or we have the other side of the coin, which is the Jan, if you want. It's the parasympathetic response, which is called rest and digest. It's the system that is going to take advantage of gathering energy and store it in order to use it in the moments that will be needed. And this balance between the sympathetic and parasympathetic is what is creating the equilibrium, the allostasis of our internal medium. And the disbalance of that is what it caused disease. We know always that the disease starts by a disbalance inside of the cells that is going to cause, obviously, cell damage. That if that goes on, then it will create a tissue damage and a disbalance in all the systems that will lead into disease. So this is why we need to maintain this balance in order to be healthy. We know, and there are some articles already proving this theory, that heart rate variability appears when mammals were living in low oxygen environment. So heart rate variability somehow is a way to get the maximum energy from the environment. It appears, as I said, in the mammals when they were living in low oxygen environments. As they are multicellulars, we need obviously a pump, which is the heart, which is going to expend energy. And we are going to use that heart in order to collect the oxygen that with the glucose, we are going to produce ATP, which is energy. So we need to be very sure that the heart is not expending more energy than the one that we are going to collect. That's why the nucleo accumbens and the nucleo ambiguus are the two nuclei that are going to manage how the pump, so the heart, is spending that energy in a way that through the 10 cranial pairs, through the vagus nerve, that it's connected to different stretch receptors at the terminal of the bronchus, are going to detect when I'm in inspiration, and that information is going to travel to the nucleo accumbens, and it's going to stop the release of dopamine, and it's going to connect to the sinus node, releasing the sympathetic and stopping the parasympathetic activation, so the heart will beat faster. And the other way around, when we are in aspiration, the nucleo ambiguus will be activated, and the brake of the parasympathetic will stop the activity of the sinus node, making the beat-to-beat distance a little bit bigger. So we have this variation between beat to beat. It's not always the same. If that is the case, we are very near to death, as I will show in different papers. So if I have a person who is on a heart rate of 60, it doesn't mean that the distance between beat to beat is 1 second. There will be beats that will be lower than 1 second, and normally that will be during inspiration, and other beats that will be longer than 1 second, and normally that will be an aspiration thanks to the nuclear ambiguous activity. This is known from a long time. It's not a very new parameter at all. On the 60s, it was more analyzed, and it was thanks to the neonatologists that were looking at how the survival of neonates was bigger, or the other way around. The prognosis of the neonates were lower when this heart rate variability disappeared. So as I explained you, this distance between R to R are going to change depending if I'm in inspiration or in aspiration. In inspiration, the distance gets shorter, and in aspirations, the distance get longer. And we can draw this in a paper, and we will obtain a tachogram in which we will see a sinusoid that is showing how this sympathetic parasympathetic balance is working. And the way to do it has been already established in these guidelines published some time ago in the 90s this is a document of consensus from the North American Society of Pacing and the European Society of Cardiology, and they made this task force in which they established that heart rate variability is the best way to assess autonomic nervous system, and more concrete, the high frequencies of that heart rate variability is showing the activity of the vagus nerve, or the parasympathetic activity. So as I was saying before, we can get this tachogram just representing graphically how the distance decrease in inspiration, as you can see the eye below, and increase in expiration due to the long distance due to this ambiguous activity that I was explaining before. So this, in somehow, it's like the EEG of the autonomic nervous system, and we can analyze it as we did with the EEG. Normally, with Fourier analysis, we can do an analysis with fast Welle transform or with entropy. That is what we call a spectrum analysis or frequency domain analysis, but we can do as well temporal analysis or the domain measures, in which, for instance, we can calculate the standard deviation of the RR distance, of the root square deviation of the RR distance, that are measures or metrics already known, directly related to, for instance, the SDNN is directly related to the total variability of the signal, which represents the total power of the autonomic nervous system, or the RMSDDN, that represents, obviously, the activity of the parasympathetic. In terms of the frequency domains, we've got three very different frequencies. We have the high frequencies, we have the very low frequencies, and we have the low frequencies. The very low frequencies are directly related to the corticotrope axis and the temperature. The low frequencies are directly related to sympathetic activity and baroreflex activity, and the high frequencies, as I already said, because it was already described in the document of consensus, it's directly related to parasympathetic activity. And as I expressed before, heart rate variability has widely studied in neonates, talking about the viability or the capacity of those neonates to go over those births. And later on, it was used as well by the cardiologists using long-term measures through 24 hours of ECG measures. They were calculated offline, and they were able to see that there was a correlation to mortality in patients with cardiac problems, with low heart rate variability and mortality, as I said, and the other way around. Those patients who have a high heart rate variability, they were more likely to survive to those cardiology problems. And then from that, it jumped into the sports area, the sport medicine area, in order to be sure that overtraining does not occur. And nowadays, you can easily measure your heart rate variability through the camera of your phone. There are different applications that you can download. This is one of them, heart rate variability for training, or there is others like Welltori, or even you can measure your heart rate variability in those smartwatches. For instance, Garmin or Sunto or others have this measure, or with the Whoop belt as well. And this is just an example of my training for the marathon that I did last year, how the training was, thanks as well to good descanso, which means rest, which good rest. You need obviously to enhance your sympathetic during the training and not overtraining, and then to have a good rest in order to allow your autonomic nervous system to recover. Then you can see that your parasympathetic and that your autonomic nervous system capacity is increased in order to be able, obviously, to face the biggest stress that represents a marathon. And that is just my improvement during the training. And you can see how the marathon caused a very big decrease on my capacity in the autonomic nervous system. So you can see here all the different applications, etc., that you can use daily. This is in the left side, you can see this application that is called Welltori that I used as well daily in order to see which is my stress level. This was this morning. I have lower stress and good energy in order to start my daily job. But obviously, we have the ENI, which is a medical device. It has not anything to do with the other ones. This is a very much precise and specific way to assess your autonomic nervous system. This is what you need when you are in the OR or in the ICU. The ENI, it's the acronym of of analgesia nociception index. But in fact, what we're looking at is at the high frequency normalized, so the percentage of the parasympathetic activity that I am having, and as well the energy, as I will explain you later. It's just talking to you about the total amount of autonomic nervous system, which represents your capacity to face the different threats that you're going to find. So as I was explaining to you, we are going to get this ECG, and from that we are going to get the tachogram, which represents, is like the EEG of the autonomic nervous system. And through fast wave left transform, which is very similar to what happened to the light when it goes through a prisma, we are going to look for the different frequencies that we obtain, the VLF, the LF, and the HF, as I explained. And we are going to just filter out the high frequencies because we are looking for the parasympathetic activity. So we filter out the high frequencies, and we are going to pass away again, and this is what is different, the high frequencies information through fast wave left transform on reverse, and we are going to obtain a curve. And for the first time ever, you can see the parasympathetic activity of your patient in real life. So this pattern, this green pattern that you can see here, the wider it is, the more parasympathetic you have. The full square represents the total autonomic nervous system, and the green pattern represents the percentage of the parasympathetic. So what we're going to do is just to calculate the area under the curve of that pattern, and we are going to obtain a number which is a percentage, and that number will be the yellow ENI or the orange ENI. The yellow ENI is the instantaneous ENI, and the orange ENI is the medium ENI, that represents the percentage of parasympathetic activity that you've got in the previous 2 minutes for the yellow ENI, or in the previous 4 minutes for the orange one. In fact, the yellow ENI will respond in 56 seconds. So if I made an stimulation, I will immediately see a change because it is updated every second, and it will reach the lowest value in 56 seconds, and the orange one will reach the lowest value in 2 minutes. And you can see as well, as I see you in this, as I told you in the screen of the monitor, the respiratory pattern that will tell you and will react immediately every second. This pattern change, and you can see that, for instance, you have a very wide pattern in a patient before the skin incision because the patient is with a good analgesia and a good hypnosis and very low level of stimulation. So it will be a wide pattern, which means a very high parasympathetic activity. And when the surgeon starts the incision, if the analgesic is not enough, then you will see that this pattern narrows very much. So the percentage of coverage decrease very much. So the ENI yellow will start to decrease rapidly, and so on, the orange one. You can see as well another value that is called energy. Energy is directly the SDNM value. It's measured in milliseconds, and it tells you about the total power or the total capacity of your autonomic nervous system. In healthy patients, you will have a total power between 0.8 or 1.2, 1.5. This is a healthy person, young person, a person who has a lot of health, if you want, a lot of vital capacity. And if you have a frail patient, that energy will be lower in that awake patient. So this is a parameter that could be very useful in order to assess if that patient may have any potential if I do a fast induction, for instance. A frail patient will have a value of energy around 0.3, 0.2 if he's awake. Anesthesia obviously will decrease that autonomic nervous system capacity, and in a healthy patient you will see values of 0.2, 0.5 normally. In a frail patients you will see like this one with an energy value of 0.08 or 0.09 in this case. This means that your patient is very likely to have a very low capacity of the autonomic nervous system, so you may have some problems. This could be as well a reason of overdosing of sevoflurane, for instance. No, allogeneic normally causes very much decrease of the energy values. This is just the formula of the energy, just in order to show you that this is a metric of the autonomic nervous system, and it's exactly the same one than SDNN, which is known to be the total capacity of the autonomic nervous system. And this is the correlation of the ENI instantaneous and the ENI M or media with the HF-nu, which is very similar to HF-nu. The validation, we have nearly 120 papers talking about that, but this is probably the most interesting one, the Funke study, which is proving that ENI is responding to nociception stimulation much better than heart rate and blood pressure. You see here the ROC curves of a tetanic stimulation and intracutaneous stimulation under propofol, and we took the reactions of different parameters like the pupil dilatation or contraction. You see the SPI, the surgical plethysmography index, and the heart rate and the blood pressure, and you can see as well the BIS number in the black dotted curve. So you can see that the highest area in the curve corresponds to the pupil contraction and as well to the ENI parameter, which is probably higher in the intracutaneous stimulation and a little bit less in case of the tetanic stimulation compared to pupil, but it's obviously over the 75% of coverage of the heart rate and blood pressure. But the most interesting thing is that when you add remifentanil, heart rate and blood pressure goes to 0.5, while the ENI stays on the 90% of coverage. This means that you cannot use heart rate or blood pressure when you are giving opioids to your patients, because the capacity of detecting noxious stimulations by heart rate or blood pressure is just the same one than tossing a coin. So when we decide to add more opioids because heart rate is going up, what you are doing is just tossing a coin. So you will be, it will be better if you use something much more specific, like it has been shown by the ENI. And the ENI, as I told you, is a percentage of the parasympathetic activity. So it's a scale that goes from 0 to 100. 100 means that the whole activity of the autonomic nervous system is parasympathetic. So probably you will not have an awake person in that case. Normally, awake patients will be between 50 and 70. If he's in comfort, he will be much around on the 70%. If he is stressed with a high sympathetic activity, he will be below 50. And this is just a publication that is correlating the ENI with the hemodynamics. And you can see that the correlation is just the 75%, because if we see the results as well from Funke, obviously we were nearly about 100% correlated to nociception, and 75% is the correlation of the hemodynamics to nociception. So obviously the correlation of hemodynamics with ENI is 75%. What we saw is that we react faster than hemodynamics 10 minutes before when we are talking about non-invasive blood pressure, and around 4 minutes when we are talking about invasive blood pressure. And we saw as well that when we have an ENI of 48, this is the highest sensitivity and specificity for detecting an hemodynamic reaction. That's why as well the index, we talk always to maintain the index over 50. And when we arrive to 30, there is always a 100% of probabilities of having an hemodynamic response in the next 10 minutes. And when we are over 82, there is no response at all. That's why as well it comes this 50-70 range. So ANI in the OR is useful in order to titrate analgesics, and it will be useful maybe as well to screen the frailty of the patients. This is the Upton study, the one that is showing that when you use ENI compared to an hemodynamic guidance group, in laminectomy, in anesthesia, and fentanyl, and improve in the score of pain, in this case, RS scores. So the group of patients that are their fentanyl, their analgesics with ENI intraoperatively got scores of 3 and 4. Hemodynamics had a score to 7. And obviously, due to that, the amount of fentanyl given post in the hemodynamic group compared to the ENI group. And obviously, effects as well. I mean, 92 more scores, 30 packs, more opioid area. So about screening this frailty, it's an interesting editorial when it was launched that it's making the control of the autonomic nervous system important to our CI. Mulier already responses of the yes, and they were saying preliminary results that low heart rate variability is a predictor of a weak aesthetic tone, a weak system activity, and independent predictor of mortality after non-cardiac. And there are papers already showing how patients with a lower heart rate variability before major abdominal surgery has postoperative morbidity at a lower heart rate variability. Or this other study that directly correlates the heart variability, so the SDNN parameter, or what it means, to increase of mortality fractures 6 months after the operation, with a in mortality than heart rate variability. Mentioned as well, ERAS program, what it obviously is the same thing that with training is to enhance the autonomic, repair the autonomic nerve in order to be able to go through the threat, which is sport, a marathon, or in the case of the OR, obviously this surgery. The ANI can be used as well in order to titrate, especially under mechanics. If we use it for just 1 hour and use it, we're going to have 1 week. And of course, it could be a predictor of mortality and prognosis. There is publications already. This is just a study that has been done in critical care patients. And I was able to detect them with a decrease in the value and the burst after that stimulation. And as it was proven that you can use the ENI with, this is just the case of an ENI monitor through the time in the ICU, in which you can see that, for instance, and comfort CNI, so it activity, and then you can increase it by a bolus of analgesic. We go 1 to 100, and then the pharmacokinetics of the drug, it goes, there is a drop in that value, and then when we end up the path, it increases. About the mortality publications in September or general that were set, so a low heart rate variability have an increase in mortality who have the power, obviously, or those with frequency ratio, which means a low sympathy has mortality than those a high ratio in terms of the sympathy, which will have a lower survival. This is exactly the same thing in case of septic pain, exactly the same. Those who have a septic process, what they need well activated in order to treat their system, and those would be likely to overcome that septic problem. Septic cause that the autonomic nervous system and exhausted, and the sympathetic go down, and obviously those patients need to start with dopamine or that sympathetic activity, and that means prognosis. There are publications same way, just showing in ARDS patients that a low or high prognosis in terms of surveillance. And obviously there is a link, a direct link that has shown between heart rate, because it is nervous system activity, and that is managing the immunitary system, so inflammation as well. This is just, that is proving the relationship between of the heart rate variability interleukin-6 release with a very good correlation. Last but not least, this is a very recent study that has been done. It's a pilot, very preliminary. It has been published in PLOS ONE in COVID-19, which these doctors were proving that those patients who have low energy value and a high frequency value, which means high Bible, who had the other pattern, cover 80 and an energy value below 0, which has this capacity of predicting mortality with very good correlation. And these are just some screenshots taken from these COVID-19 patients, in which we have high ENI showing a high parasympathetic activity with a very, very low energy, 0.0 the other case. In these patients, if I have a sedation, what I would do the first thing is to sedation in order to see if the autonomic nervous system is able to react. And if that is not the case, maybe we need pharmaceutical solutions, or maybe we should be thinking another kind of activation, right? Maybe during the first phase of the COVID-19, mainly driven by sympathetic, we should give this kind of beta blockers, or probably, etc., that will block that activation, and that very high may cause damage in the different tissues. Then what we need is to enhance, and one of those is probably parasympathetic stimulation. Already prepared, you can use even a TENS or whatever, and depending on the frequency through the parasympathetic nerve, you can activate the activation of the sympathetic or an approach just yet been proven that there's different, especially controlling the respiration time. Maybe we could control this balance of the sympathetic and parasympathetic. Application made on the Leiru in hospital, in which we had different volunteers that were just using that was able to enhance the sympathetic activity. They was not able to do that kind of LPS intravenous, and they show that the group to control the sympathetic activation, so they were sympathetic activation, so their immunitary system to control the temperature and all the symptoms injection perfectly well, while the other group are able to control, and they suffer this kind of use by this LPS injection. So that's another possibility. So in order to message of the autonomic nervous system variability, EMU and energy is total power, which will allow us to control how that surgical stress, get surgery, and this is the reason why I get better postoperative results with less postoperative acute pain, and obviously less opioids postoperatively. And it will allow us to, whatever it is, opiates, and as Dr. Moulier has been showing, in mechanical ventilation, in order to objectivize precisely which option that we are going to get in the different procedures for the patients. And another way to use it, obviously, especially, is to detect which is going to be the level of risk and mortality of our patients. So thank you very much.